It's the topic kind of assigned was rationale for dosing chemotherapy, and as you know, that's kind of a broad topic. So I really tried to narrow it down uh, for everybody. And what we're gonna mostly talk about is we're gonna talk about different chemotherapy regimens, which are mostly pertinent to Uro and GU oncology, and focusing more on the bladder cancer to be a little bit more focused in the talk. Um, we'll also review different dosing and dose adjustments of cytotoxic chemotherapy. Um, also briefly, we'll talk about the immunotherapy indications, which is kind of new kid around the block. Not new, I mean, but still early uh, data for that, and talk about the toxicities and about the management of that. So just a early heads up, we're going to talk about some trials, some statistics, some pharmacology early in the morning. So just bear with me there. Now, when we're talking about chemotherapy, so we like to call it more like a systemic therapy, because chemotherapy is kind of a broad term, and now um, the medical oncology field is not just chemotherapy. As you would know, it includes lots of targeted agents, as Dr. Balaji said, immunotherapy, and obviously traditional cytotoxic chemotherapy is still makes the backbone of it. um, it's also important to kind of get familiarized with some terms that we kind of use typically, and the new adjuvant, as you know, that's the goals of all the words, or the all the regimens are kind of different. So it might be the same chemo or same regimen, but it's important to know what we are trying to achieve. So basically, I mean, neoadjuvant is typically, systemic therapy, which is done before the surgery. The goals are a curative, to shrink the tumor, decrease micrometastasis early in the disease, and improve surgical outcomes by shrinking the tumor. Adjuvant therapies are done after the surgery or after the curative intent. It can be form of either chemotherapy alone, or in combination with radiation. Neoadjuvant concurrent with radiation therapies are also important. Again, they are more done on a curative basis. Definitive chemoradiation term used when basically patients are non-surgical candidates, and our goal is to eradicate the tumor with chemotherapy and radiation. Adjuvant chemoradiation, again done after the surgery to reduce the recurrence, local recurrence and distant recurrence. And then palliative or non-curative systemic therapy, that's where basically we are talking about advanced disease, distant metastasis, or kind of non-curative disease, where our goal is to improve the symptoms, improve the quality of life, and extend the life. Now, there are lots of, I mean, I've just put a few chemotherapy agents which are pertinent to bladder cancer. But as you know, there are, I mean, multiple agents, and a lot of different chemotherapy groups, different they work differently at different cellular levels. But you might find this familiar as we use this more, and platinum therapy remains kind of the backbone still. um, there are some agents including cisplatin, carboplatin, oxaliplatin is another one, and basically they work by alkylating the DNA. um, gemcitabine is also very commonly used chemo. Taxane, we have multiple agents, about paclitaxel, docetaxel, cabazitaxel, which we use in prostate cancer. 5-FU, 5-fluorouracil, mitomycin C, and they all kind of work on different levels, and they can be used in combination to make it more effective. And since we are kind of focusing more on the bladder cancer related chemotherapies, worth mentioning obviously MVEC, which is a combination of each of these four agents, and immunotherapy. I mean, now there are almost 5, 6, and even more coming in pipeline, but these are the ones which are kind of FDA approved yet. We have your avelumab, nivolumab, pembrolizumab, and durvalumab. There is also atezolizumab on the list there. And CTLA4 inhibitor, ipilimumab, which is used in renal cell carcinoma. Some new exciting drugs coming out, and enfortumab, which is a drug conjugate with a monoclonal antibody combined with chemotherapy. And then there are these targeted molecular agents. Just to mention a few, we have your FGFR blocker, which is used in bladder cancer now. And then there are multiple TKIs, which will not go in much detail, but as you know, cabozantinib and Sutent and sorafenib and etc. And the purpose of this, I just wanted to put it there because we have lots of options. And I mean, whenever a patient comes in the room hearing about seeing a kind of a medical oncologist or uro-oncologist about getting chemotherapy, there is this apprehension about, obviously there are stories, and sometimes there are family members who had experiences in the past, and there is kind of a shield to even talk about different treatments. But as you see, there are lots of options. Each drug has its own different toxicity, and they are indicated in different settings, and it's also important to know that about their side effects. And whenever kind of we see that patient, you can look at the whole comorbidities. And as an example, platinum agents, they have some renal toxicity, some hearing toxicities. So kind of keeping that in mind in patients with renal failure. Gemcitabine has effects on the liver. Taxane, again, neuropathy, lowering of the blood count. So we have to keep in mind about diabetic patients who have pre-existing neuropathy. 5-FU, mitomycin, which is a antibiotic derivative, can also affect the heart. 5-FU again can cause hand-foot syndrome, in more common in African American population. And so again, kind of you have your weapons to choose from against specific patients. So there are some options there. One other thing also wanted to mention is, although there are different dosing, since we're also talking about the dosing of the chemotherapy, different cancers have different dosing of the chemotherapy as well. Just to give an example, cisplatin given in a head and neck cancer is 100 milligrams per meter square, while we're gonna talk about in bladder and so forth, there are around 30 to 70 milligrams per meter square. Same, I would say, about methotrexate. I mean, we use it in lymphomas as well, and the dose of methotrexate is 100 times more than what you'll get for MVEC. So just kind of something to keep in mind, that dosing is different, the schedules are different of how a drug is administered. Now, since we are talking about chemotherapy, it's kind of important to know why or how these things come in play. I mean, there are, what are we going to talk about? Basically, it's all based on evidence, and those evidences are coming from phase 1, 2, 3 studies. And what we're going to talk about today is mostly going to be phase 3 and phase 2 studies, which is more clinically relevant. But just to kind of put a background, whenever there are preclinical studies which shows a particular agent is active against certain type of cancers, and then you'll develop your phase 1 studies, which is a small population, and you are basically evaluating your toxicities and your responses in a specific cancer. Some studies also have dose escalation in them, means different groups get different doses and see how they respond over time. Now, since we are in the era of immunotherapy and targeted therapies, um, these data or these drugs are mostly initially started in a metastatic patient, where basically they are kind of running out of options in subsequent lines of therapy. And the reason for that is kind of um, you get an answer in a short interval time. I mean, you compare the drug with the placebo, and in that setting, you're gonna get a quicker answer. You see if there is any improvement in PFS and your overall survival. So most of the data specifically for immunotherapy and this target therapies, they are used as a subsequent lines of therapy, and then as you see more and more benefit, now they advance the same medicine in a early line of therapy, means first line metastatic setting or locally advanced disease. And now basically then they are compared with the standard of care, which might be chemotherapy. So this is kind of a sequence of how kind of this new drugs are coming into the picture. And um, that's why whenever we kind of see the data, you're going to mostly see the immunotherapy, which was tested as a second line therapy against placebo. Immunotherapy was better. Now basically it's been tested and being positive data showing first line setting in metastatic setting. And then now there are also ongoing trials of combining chemotherapy with immunotherapy versus chemotherapy alone. So this is kind of how this the FDA process and how the data is coming out. Now, talking about malignancy and cancer, I just put a brief algorithm here of how this changes happen. And as you know, it's all into the cells and the mutations which develop over time, and depending on different risk factors, smoking, age, etc., there is mutation and formation of different genes which get affected, and that leads to either dysplasia or low grade urothelial carcinoma or high grade. And as time comes, more and more mutations accumulate over time, and that leads to invasive carcinoma. And the goal of this the new therapies are becoming more and more targeted in approach, means if there is a particular mutation, uh, if we have a medicine that can inhibit that mutation, it has shown that the toxicities are less and the effect is more. Again, just to reiterate that there are different. Previously, again, there was urothelial cancer, but now there are based on their immunohistochemical staining, and now we also have a next generation sequencing with NGS. We know there are different mutations and which they behave differently, and then they respond to different drugs. As an example, you have your basal type cells with CK6 positive, and they are more chemosensitive compared to you have your GATA3 positive with no mutations, ERBB negative, and they are kind of considered chemo-resistant. You also have now your luminal subtype with FGFR mutation, and there are targeted inhibitor for FGFR3 mutation. So so as more and more data is coming out and more next generation sequencing, there is more information on treating these cancers in kind of a more targeted approach instead of one umbrella therapy. So now I think when we are talking about bladder cancer, just talking about some principles of therapy of how these things come. Now, previously, as you would know, the many years ago, and this trial is old. I mean, almost 20 years old, but still is kind of the standard of care. And previously, surgery was the mainstay of treatment. And then there was this trial, phase 3 trial with Dr. Grossman and the group, basically showed, it was compared neoadjuvant treatment for muscle invasive bladder cancer. Now, we're going to talk about this in a second, but MVAC was used for mostly metastatic setting back then. And as we talked about, whenever these trials are coming out, they are tried a particular regimen in a metastatic setting, then they come into more into adjuvant and neoadjuvant setting. So MVAC was used for that already. But then there was this trial showing if there is a muscle invasive T2 or higher disease, which is still resectable. Um, Two groups were compared, basically upfront cystectomy versus MVAC followed by cystectomy, around 300 patients, and the survival was significantly improved from 44 months to 77 months with neoadjuvant chemotherapy. It also improved response rate, pathological response rates. It's the same trial. Basically wanted to show the survival curves and looking at obviously the curves being separated and stay separated over time. The hazard ratio was also statistically significant. And again, they compared different T2 levels, means T2, T3, and T4. And regardless of their level, I mean, as you know, T3 and T4 has worse prognosis even without chemotherapy, but there was all improvement. This is from that, and this is from that. So the curves went, um, the survival was improved. Now, this is high dose MVAC. So previously, the treatment was a standard MVAC and without GCSF. And GCSF is granulocyte colony stimulating factor, or Neupogen, or at that time it was a different brand name. But that was used as with MVAC, there is a significant risk of neutropenia, and that really kind of limited the treatment numbers and also increased toxicity. Now, with the use of GCSF, you can do higher doses, and you can also do it in a dose dense manner, means instead of every 3 weeks, you can consider every 2 weeks of MVAC. And with high dose MVAC with GCSF support, it showed there was improvement in the CR and PR, 72% to 58%, and median survival was not I would say not crazy improvement, but there was definitely improvement in the toxicity. So you look at the 20% risk with GCSF, and without GCSF it was 62%, which is very, very high. Now they did say the hazard ratio was 0.76, so improvement around 25% in risk of reduction. Okay, I'm gonna skip this one. Now, this data comes more from a metastatic setting, where basically the comparison was done between MVAC and gemcitabine and cisplatin. Now, the purpose of that gemcitabine and cisplatin is used in metastatic setting alone, but the toxicities were a concern with MVAC. So basically, this trial showed there was not a significant improvement. I mean, the hazard ratio is almost crossing 1, and also the p-value is also 0.6. And as you see, the graphs are really overlapping, means not one regimen really superior than the other one. So gemcitabine and cisplatin, which is kind of now the standard of care, um, that's an option. The use for gemcitabine and cisplatin, it's also important to note that the risk and the toxicity profile was much better with gemcitabine and cisplatin. Um, and again, you see more thrombocytopenia and anemia with MVAC. So just to kind of make that point, that this is how kind of the different trial regimens are compared with, and the same principles are now used for neoadjuvant therapy as well, since gemcitabine and cisplatin is kind of non-inferior or equivalent to MVAC with less toxicity. Gemcis is kind of used as a neoadjuvant regimen as well. Now, immunotherapy and its effects. So, I mean, I just wanted to put few slides here. Definitely, it's very exciting. I mean, when these drugs came first to be used in melanoma, and it was, I mean, very exciting times, like the metastatic melanoma before immunotherapy, the prognosis was really very poor. But with the use of CTLA4, which is the ipilimumab, which you might have seen, we use it in RCC, renal cell carcinoma, that really changed the paradigm of how melanoma was treated. So that was kind of the first one of the first immunotherapies to show activity. Obviously now, you know, your PD-L1 inhibitors are there in every most of the every cancers that we know of. It's been used for that. But to see how this CTLA4 inhibitors work is basically you have this microenvironment of the tumor, and then there are CTLA receptors on the T cell. And whenever this CTLA keeps the T cell under control, but when you block that CTLA4 with the drug, is basically it activates the T cell, and then there is a whole immune cascade of activation of the T cells, then dendritic cells, and then interaction with the tumor cell. In compared to PD-L1 and PD-1, PD is program death ligand, PD is just program death, which is not a ligand, so which is on the T cell. PD-L1 is on a tumor cell, and to be honest, both of them are, their toxicities are similar and their efficacy is also similar. So there are the PD-1 inhibitors are nivolumab and pembrolizumab, and your PD-L1 is atezolizumab and durvalumab. And again, kind of important to notice the toxicity profile with ipilimumab. It's a really, I mean, it was when it was initially used in melanoma, the dosing was 10 milligrams, which is really which was really a high dose. A lot of people had significant immune toxicities, while now in renal cell and other non-small cell lung cancer even, the dosing is really on the lower side with 1 milligram per kilogram. So that has improved the toxicity profile of immunotherapy. Now again, some new data, exciting data coming out for non-muscle invasive bladder cancer as well. Again, kind of making the point, new therapies are being used in early stages of disease. So as you know, from metastatic setting to muscle invasive setting, and now in non-muscle invasive disease as well. And still early data, I mean 100 patients, Keynote 57, on your high risk BCG unresponsive carcinoma in situ or papillary disease, who had inadequate response, who doesn't want to go cystectomy, got pembrolizumab for 2 years. And there is exciting data, definitely, I would say, who patients who refuse to undergo cystectomy, or who are not medically candidates for that, and it has shown that it has maintained CR on long follow-up, and there is also none of the patients progressed to muscle invasive or metastatic disease. So definitely there is more and more. Again, we need a bigger trial, but this is definitely very exciting. Now, coming to the stage 4 disease, where really we have very strong data to use chemotherapy and immunotherapy. and you have your T4B lesions or node positive disease or distant metastasis, systemic therapy still remains the standard of care. And that's the mainstay of treatment to improve survival. As you know, bladder cancer, sometimes they even present with metastatic bladder cancer, or most of the patients, they relapse, half of the patients after surgery, and they have distant metastasis, and the metastasis varies, lung metastasis, liver, bone metastasis are common, but CNS is kind of rare, but we've seen it occasionally. Now, cisplatin again remains the backbone for bladder cancer, and your category 1 recommendations, as we earlier saw, still remains the gemcitabine and cisplatin, while your dose dense MVAC is still category 1. I mean, it has shown improvement in survival, so it's still category 1. But we saw that the trial between these two, they are basically equivalent or at least non-inferior with gemcitabine and cisplatin with more favorable toxicity profile. So so still, I think gemcitabine and cisplatin remains the backbone, while reserving the doxorubicin for later downs of therapy. Some new data coming out now, maintenance therapy. So typically when they're a metastatic patient and you start them on gemcitabine and cisplatin, there is a fixed number. I mean, you have to stop with those chemo, and typically around 6 cycles or 6 months of treatment, those will be the kind of a max of cisplatin and gemcitabine a patient would tolerate, and after that the toxicity kind of can increase. So after that, typically the treatments were to kind of observe them, and if they progress, then start a next line of therapy. But just recently, again September of last year, and this is an ongoing trial of using pembrolizumab and avelumab. Again, both are immunotherapies, both are PD inhibitors, and they are basically compared after they get chemotherapy 6 months. You put them on a immunotherapy maintenance, and the reason for that was to see if there is any improvement in survival. And there was in the overall population, as you see, the median overall survival in the avelumab group is superior, is around 21 months versus 14 months, which is definitely statistically significant. Hazard ratio 0.69, p-value 0.001. Now, there was a subgroup analysis in a PD-L1 positive population, and as you know, there is definitely more separation in the group. The median overall survival was not reached, and again, the hazard ratio was very significant. Now, again, just to be not to be devil's advocate, but whenever sometimes these trials are released, you see the data of the PD-L1 population and overall population, but sometimes they don't release the results of PD-L1 negative population, or who has PD-L1 of 0% or CPS score of 0%. Now that's where kind of it's a gray zone of where what to do with those patients. Eventually, FDA and all the regulatory companies do ask for a PD-L1 negative population data as well. So that does come out later in the line. But at this point, this is what we have with overall population having the benefit. So there's definitely a role for maintenance therapy. Now,
so,
yes, Dr. Balaji.
just a comment.
Yes.
This indication has been voluntarily withdrawn now with the
Yes.
FDA. I don't know what the issue is. So currently, the company has requested for voluntary withdrawal of approval of available for maintenance therapy
Good.
in post-chemotherapy settings. So
Yes, maybe they might be waiting for the data to mature and to see the whole population. So that was a good call, kind of.
so yeah, this is not, it was approved, now that approval is withdrawn.
Yes.
So just people to be aware that currently we do not have a maintenance protocol for people who are
Yes,
responding.
yes,
The Pembro study comes out, I anticipate it will be similar effect.
yes. Thank you.
Yeah.
So yes, so there was some data on that as well. Now, cisplatin eligible. Now you have your, again, you can use substitute cisplatin with carbo. So carbo you can use in patients with renal insufficiency, just need some dose adjustments. And definitely atezolizumab remains an option who cannot get any platinum therapy, or is an option who have PDL1 positivity upfront. Same thing with pembrolizumab as well. If patients have PDL1 positivity, or who are not eligible for any platinum, either cisplatin or carboplatin, regardless of the PDL1 expression. Now, cisplatin, so this can be kind of um, obviously, if the heart failure is controlled, that we use cisplatin in that setting. Um, some people also do a split dose. Um, so it's kind of a very strict criteria of GFR less than 60 that was used in the trials. Um, Again, atezolizumab, there was the data of cisplatin ineligible patients. Again, kind of, it was not compared with anything, so you don't have anything to go over with, but you have your response rate, which are very acceptable, very reasonable. Overall survival, again, very acceptable in the first line setting. And this also tumor, you need CPS score of more than 5% if they are cisplatin ineligible. Same data with carbo as well. I'm sorry, with pembro as well. Your response rates around 24%. Also stable disease. So this is important as well, because sometimes even in a metastatic setting, stable disease is still acceptable. So, and you can keep them on the same therapy if they have stable disease. So around 40 to 50%, maybe you might be able to keep stable disease. Um, just kind of something to keep in mind, the CPS scores are kind of really, really important and different. Pembrolizumab has its own drug testing, PDL1 status testing kit, versus atezolizumab, they have their own. So again, kind of have to keep in mind which CPS are we using. Now, metastatic second line therapies, we have lots of options now. Previously, docetaxel or Taxol-Boy's regimens was kind of was mainly used, but now there is new data coming out for enfortumumab and also for FGFR blocker. So just wanted to kind of I think the keynote we
Gharia,
already
I
know. Yes.
just had one comment because we have
Yes.
a lot of residents and fellows on the
Yes.
call, including extenders. With regard to PDL1 expression, so as a group knows, we look for two other biomarkers to respond to chemotherapy. One is the mutation burden, and the
Tumor,
other
yes.
one
TMB.
microsatellite instability.
Yes.
Now, with regard to PDL1, each study has used its own type of assay, and a lot of
Yes.
these assays are not reproducible.
Yes.
And the other challenge is the threshold. We saw
Yes.
one study said
5
1%, the
and
other said
10.
5%.
Yeah, yeah, yeah.
So that's why, we're really not sure, right? So we
Yes.
don't use these biomarkers now at this time because a lot of uncertainties around it. We give
Yes.
them, if they don't have other options, we try immunotherapy and hope it works. So,
Yeah, so I mean, in that setting, it would be like any platinum ineligible, you can use immunotherapy regardless. So, and I think one thing is our pathology team, we can always maybe try to communicate which drug, if we already know beforehand, maybe if they can get that marker. There is this Vendetta marker for atezolizumab, and then there is a different one for Keytruda. So good point that it's important to see that which marker, I mean, they're doing the testing, so we can use the appropriate drug. Okay, now, okay, this was post platinum second line therapy. Again, we talked about how this chemo immunotherapies drug come. They are first initially tested in a second line setting with standard of care chemo, and Pembro was superior to that. So that's definitely, if they haven't had that as a first line, your second line option would be immunotherapy. Okay, and for Tumumab, now this just updated the results last month or so, but this was a phase 3 trial. Patients who had progression on platinum and PD-1. So that's also something to keep in mind. You can use it after, if somebody had immunotherapy before, 3 weeks on, 1 week off schedule. And uh, I mean, this enfortumumab, the mechanism of action is really very, very interesting. And there are definitely other drugs where there is a monoclonal antibody combined with chemotherapy, and the first one was TDM1, which is used in breast cancer most likely right now, with where there is a trastuzumab, which is a Herceptin combination with chemo. So again, but this is a interesting concept. And it works basically on Nectin-4, and I tell my fellows that N4, that's how the name maybe came out, N4, Nectin-4. And for Tumumab, Vedotin is type of a chemotherapy, and I put the picture here how this kind of works. So you have your antibody here, and you have your drug conjugate, which is the chemo, and it binds to this Nectin-4 receptors. Now your Nectin-4, you obviously have it on the bladder tumor cells, but you also have on normal cells. So there is definitely toxicities related to that, that we'll talk in a second. But this antibody drug conjugate gets internalized, and then the chemo part is released into the cells, and it's a microtubule inhibitor, so similar to your Texans, and that's how it kind of inhibits the microtubule disruption and stop the multiplication of the cancer cell. So it's kind of interesting mechanism. um, and it was a phase 3 trial, fairly large number of patients, very reasonable response rate, 40% for a second line, and disease control rate as well was very impressive, I would say. Overall survival with hazard ratio of 0.7, and PFS was improved as well. Now, one thing kind of we have to keep in mind that, again, this sounds more like a monoclonal antibody, but it's still a chemo. There is chemo in it, and the grade 3 toxicity is pretty similar. It was similar in both the groups, and the other group was basically chemotherapy, and that was investigator's choice, either docetaxel, paclitaxel, or vanfluminine, and um, there was a similar rate of toxicity. So we have to keep in mind again that there are toxicity risk, diarrhea, rash, and some other side effects, leukopenias, something to keep an eye on. So not a completely benign drug, I would say, but definitely a very strong option for a second line therapy who has somebody progressed on immunotherapy. Okay. Again, targeted
Dr.
agents.
Gharia, just
Yes.
for our own education,
Yes.
in urology, this is the first monoclonal drug conjugate that has
Yes.
shown improvement in survival. How about other cancers? Is this
Yes.
commonly being used?
So this is new. I mean, as I said, the first one we had was TDM1, which almost came out 5 years ago. And that's used for breast cancer as a second line agent. The other, and again, that has acceptable toxicity, again, similar. So they do have some overlap, toxicity with chemo. Hair loss can happen, some nausea, cytopenias, and related to the monoclonal protein, allergic reaction, diarrhea, rash. So but yes, so coming to your question, so yes, so in breast, TDM1 has been used for a long time. uh, Hodgkin's lymphoma, so there is a brentuximab, which is kind of it's a monoclonal antibody with a drug conjugate, so that also has been used for some time. um, there is this new drug coming up, sacituzumab. Again, not it's not it's in a phase 2 trial. Again, that's for a bladder as well. um, Let me put a slide there if we have some. But that's a similar drug. So this is a um, new mechanism, and there are a couple of pharmas who are kind of working really on this antibody drug conjugate. So yes,
Thank you.
thank you. um, Now, edafitinib, now there are definitely FGFR is highly expressed, or the mutations is prevalent in bladder. It's also present in certain other malignancies. We also know in leukemias, FGFR mutations play some part in it. But regarding bladder, there was phase 2 data on patients who progressed on first line of therapy. Immunotherapy use was allowed, and again, you had reasonable response rate. It was not compared to anything, so again, we don't have a comparison. But PFS was 5.5 months, and overall survival again was 13 months. So or this NIPS or IPS, again, they are all kind of targeted agents. MAPS, as you know, are all monoclonal antibodies. So, something to kind of remember by. Now, chemotherapy toxicity. Now, that's a big topic to kind of cover, but just I wanted to put free some guidelines. Obviously, whenever we are offering any treatment, we have to look at the each trial and look at the adverse events into those trials. Monitoring labs frequently before treatments, their clinical status, management of toxicities based on grade. Many times, if it's chemo, dose adjustments, omission versus avoidance might be needed. uh, Geriatric care, and I think that's really a very important and emerging areas of investigation, as we are seeing, I mean, patients in their 80s and in their early even 90s. We have some patients, and really it's important to choose wisely what we're going to offer, and look at the comorbidities, etc. Also important to see trial patient versus real life patient. Is really different when we have to look at the median age of the patients used in the trial. So toxicity management is kind of a key whenever we are kind of using any of these medicines. um, just to kind of give a brief thing how these toxicities look like. And I mean, most of the trials, they do give you your grade 3 and grade 4 toxicities at least. And this was from the MVEC trial, so I just put it here. And there is the CTCAE. Now, that's a separate book of each toxicity, and I just put a brief example here how that might look like. And so suppose if somebody has a diarrhea, a grade 3, so that can kind of give you an idea what grade 3 is. And whenever there is like a clinical trial or a protocol, it's important to mention and document your grades of toxicities, so appropriate statistics can be obtained and those can be adjusted. Again, you have these grades for each and every system of your body, and I mean you have it for conjunctivitis and for neuropathy and etc. So there is a grading system for management and evaluation of toxicities. And this is basically the CTCA5 version 5.0. And as I said, you have each and every, system which we can think of, eye disorders and infections, kidney dysfunction. So you have to kind of keep in mind of different toxicities and document and make those adjustments as necessary. Immunotherapy toxicity is a completely separate thing. Now, as you know, the side effects of immunotherapy are really different than your traditional chemotherapy. So hair loss, nausea, kind of those kind of things are very atypical. It doesn't really happen with immune checkpoint inhibitors. But there are immune related toxicity, and as we saw, it activates your immune system, and that can autoimmune diseases can kind of flare up, and really have to keep a close eye on them. It doesn't really cause cytopenia, so that's not a problem. But thyroiditis, that's, most of every patient eventually gets some kind of thyroiditis. Pneumonitis, colitis, and again, it can happen from head to toe. Any itis can happen. So again, important to monitor your patients closely for that. And um, toxicity and early recognition of the toxicity from immunotherapy is again kind of key. And there is not really a dose adjustment for immunotherapy. Means like you don't cut down the dose to 50%. It's either you stop it or you keep giving it, or you give them a break. So toxicity management is important. Steroids, prednisone, methylprednisone still remains the mainstay of treatment. But if they don't respond to steroids in 2 to 3 days, then you have to use a stronger immunosuppressant. So infliximab or TNF alpha inhibitor, especially for pneumonitis and kidney problems, and mycophenolate, vedolizumab, which is kind of another drug coming out, used for that. And again, it's kind of getting better since the ipilimumab doses have been decreased, but previously with the 10 milligram dosing, it was very, very frequent. But obviously with PD-L1 blockers too, you're gonna see immune toxicities. And again, kind of coming to wrap up the talk, where we heading. Again, phase 3 data, chemoimmunotherapy, phase 2 data, combination of immunotherapy and enfortumab. I think that will be interesting to see different mechanism of actions and how they pan out. New targeted agents based on NGS. There are lots of, other targeted agents used in lung cancer. BRAF mutation is one of them, MSI high, as Dr. Balaji said, and also certain like MET inhibitors and RAT inhibitors. There are so many other targeted agents that eventually that will come out. New adjuvant immunotherapy, new adjuvant chemoimmunotherapy, and we talked about sacituzumab, govitecan. So again, that's a monoclonal antibody and a chemotherapy conjugate, and govitecan sounds like irinotecan, so that's what it is. And so basically there is some data coming out for that as well, so we'll keep an eye on. So summary, I would say, significant role of systemic therapy in different stages of cancer. Improved supportive care and toxicity management has improved survival and outcomes. Early recognition and management of immune-related toxicity is important, and ongoing development of new agents in different lines of therapy to stay up to date, and we have to keep an eye on those. So that will be the end from my side. I'll open the floor for any questions.
Any questions for Dr. Gharia?
Sorry, Gharia. So, is there, I've seen that, many of the, trials, and some of them actually tried immunotherapy in neoadjuvant setting. What has been your experience with that, and, how much it is recommended?
Neoadjuvant immunotherapy.
Correct, in bladder cancer.
So I have not used that in that setting yet, I mean, outside of a clinical trial. I don't know how reasonable that would be to do, but I think one answer to that would be if we have used that in locally advanced bladder cancer, and when they are kind of not a candidate for resection. And I mean, you can have a dramatic response, and everything kind of, you can have a complete response to the immunotherapy, but again, we have to do the patient go for surgery at that time? um, Not typically, so I'm not sure if Dr. Balaji has any thoughts on that.
Yeah, Dr. Bandek, who does our bladder cancer work, actually wrote a proposal with Pfizer, which unfortunately did not get funded. It went up the chain, but at the final moment, they did not fund it. So he was proposing to use neoadjuvant immunotherapy prior to cystectomy. At least there's one study out there that said the response rate, P0 rate, is pretty high. It's in the high 40s. Is the right mark 40 or 50% mark?
Yes, that's a good, yeah.
Yeah. So if somebody is unwilling to get neoadjuvant chemotherapy, it may be an option. But you're right, though. We are currently using this more at a locally advanced stage rather than truly in a neoadjuvant setting, awaiting phase 3 data. My feeling is that's probably going to be the future. Given the toxicity profile for chemotherapy, I think immunotherapy may be a preferred option. The other challenge we have with neoadjuvant chemotherapy for bladder cancer is if we look at the pooled analysis, I think the overall survival is about improvement in survival is about 5% between getting neoadjuvant and not getting neoadjuvant. So that is one of the limitations, this effect size. While it's certainly improvement in survival, the effect size is rather modest. We're hoping that immunotherapy will change the paradigm. It will probably be the standard in a lot of these patients in the future. But currently, we're not using them as standard.
Yes, and I mean, similar thoughts have been proposed for, I mean, outside like lung cancer too. And because again, when there is a dramatic response, I mean, many of the times there is just no disease left on the next scan. So really, that is very exciting thing, and looking forward for like more mature data to come for that. So.
Any other questions for Dr. Gharia? Okay. Dr. Gharia again.
Sorry, Dr. Gary. For neoadjuvant, you're like comfortable using GemCis instead of MVAC or dosed at MVAC, which I mean probably has a more P0 rate as compared to GemCis. Although I know they're not inferior.
Yes, I mean, again, we have to look at the person as well, very young person versus older population, and GemCis definitely has better toxicity profile. So whenever, if that's a concern, even in even slightest, then I think GemCis is more reasonable compared to if a very young person, 40s, 50s, who can kind of robust looking, and I think then you can argue about MVAC in that setting. But typically in our population, more than 65, 70 years, MVAC can be tough. So really have to choose your patients wisely there.
So the other thing, Umar, we kind of be careful with MVAC because it is both contain cisplatin, but one of the things we concern about these regimens is the risk of DVT. And at least, I don't know whether Dr. Gharia has seen this. Anecdotally, we have seen a few patients who developed chemotherapy, DVTs on chemotherapy that made surgery more complicated. They had to postpone surgery because of need for anticoagulation and so on. So one other side effects we can manage, but DVT or a VTE is something that interferes with timing of surgery in these patients. So.
Yes, I agree.
Thank you.
Any other questions for Dr. Gharia? Okay. Dr. Gharia, again, thank you so much.
Thank you, Dr. Balaji. It was my pleasure to talk, and looking forward for future communications.
Yeah. And let us know. We got a lot of clinical trials here. As now we are on board, we can come up with joint effort to advance the program.
Thank you so much. Thank you. Thank you, everybody. I'll sign off here and take care.
Okay. Thank you. Thank you, guys.
Thank you very much.
Now, do I have, okay. Thanks, everybody.
Thank you.